Good day, my dear postgraduate students. Happy in meeting you after a long time. This particular class from recent advance 25 has been one that I had been willfully postponing for quite some time. There are several morals included in this presentation, which shall be raveled as and when the story goes. In fact, you are seeing something behind my back. There the story starts. A very wonderful compilation by Ming Zhou, and it is of the intraductal carcinoma-prostate. This is one of the best references that I would suggest. Always a topic like one from the recent advances, do not read from the text proper. It is impossible for a student to understand, comprehend, and reproduce. Try to have another source, and this one I picked up for myself and I thought would be very useful for the students. And look at the subheadings itself. I used to very colloquially say, think of the subheadings will take you to the answer. But then this is a list of subheadings which I cannot make head or tail of. They are so very technical and modern, molecular as well as microscopic, evolving as well as confusing. So let us see how much of it has been covered. These are all the headings that have been given by the author in his presentation. And it continues. Now coming to the introduction of the topic per se. See how wrongly we have understood, or rather I have understood pathology. There is a basement membrane, there is a metaplasia, there is a dysplasia, a carcinoma in situ, then an invasion. There can be an intraductal carcinoma and then an infiltrating carcinoma. This is what we have been thinking of. But then look at these words over here. Intraductal carcinoma-prostate is a unique form of aggressive carcinoma. The words, each letter is worth its weight in gold. It occurs within the native prostatic ducts. It is an expansile lesion, may be solid or cribriform, and there can be or will be nuclear atypical. So these are the important things. So it is not a preceding lesion, but rather an accompanying lesion, which can be an indicator. A very important moral story for the day. Suit the action to the word and the word to the action. Sir William Shakespeare. There is a lot to be read about the prostate. I shall be definitely coming back to it in sequence. This is, for instance, the classical Gleason's pattern of grading. I am not going to go into the text of it. It is only for a recapitulation and then to maintain the continuity with the present topic. The glands can be small and uniform, then they can be more widely distributed. You find that they can be having infiltrating margins gradually becoming irregular. And finally, you find that there can be only occasional glands. There can be solid cords and nests. So at the other end, I have got well differentiated, moderate differentiated, poorly differentiated, or anaplastic. The story goes. This itself has been taken from Wikipedia. Hats off to them. If for one topic in histopathology, I can get this amount of information. Imagine what can be done or there for the plethora of topics in various subjects cut across. So this is a Gleason's grading, and you are supposed to make a grading of it by seeing two different population of cells, their morphology, their aggression, and then you have got A plus B. And finally, you have got a Gleason's grading. So this is pattern 4, he says. HNE and nephron, it is a source of reference. I have to give the reference because the work is not my own and Wikipedia and its authors have to be acknowledged. Now, what happens is there can be a late colonization of the prostatic carcinoma with spread into the pre-existing prostatic ducts and acini. There is a carcinoma that is proliferating. It is spreading into the relatively normal prostatic ducts or acini. Again, there can be increased genomic instability. Genomic instability means it will be promoting the carcinogenesis. And there can be defects in DNA repair, which means there is no rectification. This affects the prognosis as well as the clinical course. The IDC prostate should be reported in a case of prostatic carcinoma. Generally, what do I do? When I see a case of dysplasia carcinoma in situ with an infiltrating carcinoma elsewhere, my report is going to read as only infiltrating carcinoma. I do not make any special mention of this. But in a case of prostate, this becomes mandatory. I do not know whether it is a reverse hypothesis or a corollary or whatsoever. Why is IDC prostate carcinoma important? Because it can be associated with aggressive prostatic carcinoma. Secondly, it has to be differentiated from high-grade prostatic carcinoma. The proliferation occurs within the ducts. Therefore, there was a debate whether this has to be included in the Gleason's grading or not. In 2016, WHO saw it as a distinct entity, and therefore it need not be included. In 2022, again, WHO maintained the same status. But then, now of late, it is mentioned that IDC prostate is equal to intraductal extension of the carcinoma prostate. In this case, the normal epithelium is being replaced and found together with carcinoma prostate. There is a catch with it, the caution in the term I shall be explaining later. So this can be included from Gleason's grade 4, 5 upwards. How does the IDC, intraductal carcinoma prostate, arise? There are two biologically distinct pathways. One is most ID extension of an intraductal carcinoma found close or an infiltrating ductal carcinoma found close. They have the same genomic alteration. It involves the benign glands also. And then you find that there can be these two gene abnormalities. Sometimes the ERJ gene alone is found in 100% of the cases, indicating a defective repair. Or it may present as an intraductal carcinoma or high-grade prostatic intraepithelial neoplasia. So there are two distinct pathways. One, there is a carcinoma outside and then it is extending inside. Two, as usual, there is going to be a high-grade neoplasm that is going into an infiltrating carcinoma. Again, reference and courtesy, Jatin Gandhi. So this appears to be a very simple work to which we shall be going any number of times worth its weight. And Indiana University from ResearchGate. So this diagrammatic view, it gives us a better appreciation of the glands, the discreting glands, the variation in shape, size and shape. You find that the angulation, then the cribriform pattern becoming more solid and cord-like. Finally, anaplasia is there at the cellular level. What are the morphological features? One, there is a crowded growth with more than 6 glands together. The glands that are affected are larger than the benign glands. They are loose and cribriform. Dense cribriform can occur later. Comedonecrosis can be present. Corpora amylacia, strangely, whenever I see the corpora amylacia, I give a diagnosis of prostatic hyperplasia. But then it can occur with the carcinoma. Large nuclei, prominent nucleoli, pleomorphism, and two population of cells. So this is a little difficult. I would like you to by heart word by word, nothing else. And thanks to Wikimedia Commons, look at this one, a beautiful picture. It is a case of an intraductal carcinoma-prostate, in which I am finding two population of cells. These are cells with relatively, say, amphiphilic cytoplasm and hyperchromatic nuclei, slightly elongated. Whereas here I am finding clear cells. Normally, my doubt will be whether I am mistaking it for a basal cell and then a carcinoma, or is it just a basal cell hyperplasia. These things I shall go to at a different date, but I'm just apprising you of the problems. So obviously, I would like you people at this rate to appreciate the cribriform pattern, then the two population of cells, and some cells having a clear cytoplasm, and also look at this one. This is an area, but then there is a widening of the gland or the duct, which is possible. This is again another one. So more than 6 glands. So this is abnormal, this is abnormal, this is also, and so. So within an area, I'm able to find more than 6 glands, a species of intraductal carcinoma-Prostate. Look at this again. This again is a beautiful picture. So there is a very clear demarcation. There is no infiltration. It is an intraductal lesion. But then looking at it, as I told you, I find that the cells are elongated with tall nuclei. Whereas here they are becoming more circular. There is a crowding, and then sometimes I find that there is a papillary infolding producing the classical cribriform pattern. That is an old story. But look at this fellow over here. This is the basal cell that I'm worried about. So there is a discontinuity in the basal cell. There is a prominent discontinuity in the basal cell, which is again strongly towards the IDC prostate when compared to high molecular weight keratin. So in this case, the cribriform pattern is that this is densely cribriform, this is a little loosely cribriform. But then there are two things. High molecular weight keratin. So in B, I am finding 34, B 12, and in D also. So I find that there is a positivity for it. The basal cell marker. So basal cell marker, again it is done. For example, in this picture, though the section is not very good, it is quite difficult for me to say whether it is a carcinoma or an intraductal carcinoma-prostate or even a infiltrating. Therefore, a basal cell marker is done. And here again, I'm able to find out some discontinuity. Therefore, IDC-P is a diagnosis. Now, what is the diagnostic criteria? All said and done, histology is subjective. It varies from person to person. Therefore, how at all do I make a diagnosis? There has to be the criteria. 5 major and 3 minor. So what are the major criteria over here? The large caliber glands, 2 times the normal glands. 1. Preserved basal cells with basal cell markers. 2. Cytologically malignant cells. 3. Expansile mass or a glandular lumen. 4. And comedonecrosis. So these are the, in fact, it suggests that all should be there or may be there. So these are the major criteria. Then what about the minor? So 4 major is there, fine. There are several diagnostic criteria. Right angle branching, we had seen. Smooth rounded outlines. It is not an infiltrating margin that you see in any sclerosing tube. 2 population of cells. Perimeter is pleomorphic, increased mitosis, and poor staining for prostatic specific antigen. Central cuboidal cells with glycogen maculation, positive for prostate specific antigen. So I think the major criteria are mandatory and multiple minor. These will be in favor of the diagnostic criteria. So there is something called as IDC-P, and there is a prostatic intraepithelial neoplasm, which is of high-grade neoplasm. So what happens is just as your pap smear. So there are the features, what is IDC and then HGPAN. Glandular morphology, the extent of involvement, architecture, contour, size, nucleomegaly, mitosis, RG expression, P10 loss. Now, my dear students, mug up this table. I have retyped this from the recent advance. Always a couple of diagrams and tables will complete the answer for us. All the other things you can automatically write. So extend more than 6 glands, 2 glands. Architecture is dense or cribriform, whereas here it is flat or loosely cribriform. Contour, there can be irregular branching. Here it is smooth because it is less malignant. Size, enlarged, similar to the benign glands. Nucleomegaly, pleomorphic bizarre. It is 2 or 3 times larger but benign. Mitosis increased, rare. Comedonecrosis can be present. It is rare, it is focal. Basal cells present or conspicuous. They are discontinuous. Molecular alterations, RG expression is there in 75% of the cases about, whereas it is only 18% here. And P10 loss is 80%, rare in a case of GPAN. So these are the expansions for it. Kindly go through it. I had this particular tabular column. Guo and Epstein, there were 2 people. They said that malignant cells are seen, expansal acini, preserved basal cells, cribriform pattern. More than 50% demarcated out of central and the solid luminal masses. There can be alternatives such as micropapillary, comedo, and prominent nucleoli. So this is almost a repetition, but please remember the names of these 2 gentlemen who have contributed. Atypical proliferation, similar to atypical proliferation within ducts and acina structures. Atypical proliferation is now somewhat different in entity. You take an example of the atypical hyperplasia in the breast. So the range can be anywhere from HGPAN to IDC-P. So it is somewhat intervening these 2 in between. Some cases of architectural complexity, insufficient diagnostic, atypical cells or proliferation suspicious of malignancy. AIP means atypical intraductal proliferation. Sometimes we see loose cribriform glands. So all that the message in the slide is, it is in between HGPAN and IDC. Molecular features of IDC-P. IDC-P is distinct from HGPAN. It overlaps prostatic carcinoma rather than HGPAN. ERG rearrangement is plus. There is a loss of P10. And Gleason's grading 4 to 6 shows similar frequency of the genomic instability. So in the higher number, it is correct to mix this with the Gleason's grading. Whereas if it is lower and appearing more benign, if I have more complex and atypical cells in other fields, if I'm going to mix down, I'll be bringing down the Gleason's grading and therefore the intensity of the tumor, which is wrong. So immunohistochemical stains that are useful to confirm the basal cell, Gleason group 1, P10 and ERG we have mentioned. Expression of other markers, NKX 3.1 PSA, urothelial GATA3, P63, high molecular weight, kininogen. Then colorectal CDX2 to differentiate it from adenocarcinoma of the colon. Sometimes that will be difficult. Which is the primary, which is the secondary. We have had enough problem with it. Now, concomitant prostatic carcinoma. How do you report? Okay, reporting a case of IDC-P. When there is no concomitant, what we'll do is report the presence of prostatic carcinoma. You do not grade it and you do not comment on the prostatic features. In fact, we might ask for a rebiopsy. Gleason's grading 6 is there as prostate. Do not include IDC-P in the final Gleason's score because it will bring down the rating and the grading. and you cannot comment on the prognostic significance by mixing David and a Goliath. Gleason's more than grade 7, it can be included in this because it is already very high and it has gone into the high grade Gleason. Warning: large atypical glands are seen in suspicious IDC-P without carcinoma-prostate. What do? I am finding large and suspicious glands without any carcinoma-prostate. One is basal cell immunohistochemistry is mandatory. Second one is advise a repeat biopsy because always what he says is there is a chance of a carcinoma-prostate in the adjoining tissue which has been missed. Prostatic carcinoma associated with IDC-P or atypical intraepithelial proliferation will be much greater than prostatic carcinoma without IDC-P or AIP, atypical intraductal proliferation. So this is an important dictum that you people will have to remember. So whenever there is going to be associated carcinoma, then it has got a greater significance. This is another one. There is a scoring system. I am not going into the importance of it, but then there is something called the 4K score that I came across. Now, what is this 4K? I will have to mention. 4K is total prostate specific antigen 1, free prostate specific antigen 2, intact prostate specific antigen, and kallikrein. So these are the 4Ks. And this is the first biopsy, second biopsy, description, etc. You can ask your faculty for their advice. Clinical significance. IDC-P is associated with adverse findings in both needle biopsy and radical prostatectomies. In the sense, if it is present, it carries a poor prognosis. IDC-P adverse outcomes equal to lesser progression-free survival. In the sense, if it is going to be there is going to be a lesser progression-free survival. So it will be adverse. Biochemical recurrence can be present. Increased metastatic failures. Extraprostatic extensions should be thought of and greater mortality. In fact, all is adverse. You find that the progression is more, biochemical recurrence is more, metastatic failures are more, and then extraprostatic extensions can be present, greater mortality. That is the significance of IDC-P. Now, what is the management of intraductal carcinoma-prostate with prostatic carcinoma? Since this is a new emerging entity, the treatment is also varied. IDC-P may not respond to the current treatment of prostatic carcinoma. There are various reasons. I will go into it in another class. IDC-P is enriched after androgen or chemotherapy. Multimodality and novel therapy is therefore needed. For example, now it is stated that this is a newer drug, abiraterone, is better than docetaxel, which has been used earlier in the first line chemotherapy in a case of IDC-P with prostatic carcinoma. However, they found that docetaxel is better than abiraterone in patients with metastatic castration. Look at this word, metastatic castration. Normally in a patient with a carcinoma of the prostate, they will be doing a castration of the testes also, which can be harboring. Therefore, you find in that case, the original drug is better. So there is a conflict of ideas between them, and that is yet to settle down. Should IDC-P be reported in a case of carcinoma-prostate? Including this is debatable. That's what I said. Earlier, it should not be included. WHO 2016 should not be included. Recent times, they say that it must be factored in. HNA alone is not adequate, but IHC is needed. But then, it is difficult in a developing country. Therefore, in 2019, they have come to a conclusion that it has to be incorporated in the Gleason screening. But the catch is this. If the grading is very low, do not include because it will pull down the grading further. But if the grade is going to be greater than 6, group 2, you can include it. Another school of thought says, rarely IDC-P may be a precursor lesion and hence cannot be included in Gleason's grading. At grade 6, the prognosis is not known. This might lower the grading if the carcinoma load in the biopsy is less. So these are different things. Now, what are the distinctions between the features of IDC-P and HEPAL? Histological features, IDC, HEPAL. Basal cells, present. Cytological malignant cells, always present. Severe nuclear atypia, usually present, never present. Solid growth pattern, sometimes present, never present. Dense cribriform pattern, sometimes, never. Loose cribriform, sometimes, never. Complex pattern, sometimes, but rarely. Comedonecrosis, sometimes, rarely. And partial involvement may be sometimes, but it is never. So this is again a table from that text. Now, my dear students, how to report IDC-P in 2 lines? Whenever I say 2 lines, I would like you people to get introduced to my friend Thiruvalluvar. And all of his sayings are in 2 lines. This particular saying is 1. Ormaikan Thanatra Kalvi, Kalvi Orvar Kelmayum Yema Pudaithu. Whatever one person keeps teaching, he will be gaining it in the remaining generations he is to attain. So, what is said over here is IDC-P is seen in the absence of invasive prostatic carcinoma. What we should do is ask for a further biopsy because it is highly unlikely that IDC-P is seen in isolation. This is going too near the trees. All said and done, I feel that fundamentals are fundamentals. And these are the sayings of R.A.T.S. When you go too near the trees, look at my back over here. You will be losing sight of the forest. We will not know the width, the depth, and the size of it. Thanks to R.A.T.S. And this incidentally will be the various stages of it. There is a normal epithelium, there is a prostatic, intraepithelial neoplasm, then there is a low-grade carcinoma with a breach in the basement membrane, and a high-grade carcinoma, of course. And these are all the friends, the relatives who will be visiting it. GOK. GOK means God only knows. Go and ask him. But incidentally, these are some of the markers which we people shall try to remember. Gracie Millie.